Can I now invite Dr. Kumar Prabhash to moderate the next session? The panelists are Dr. Bharat Singh Bhosle, Dr. Rohit Pal Pai, Dr. Ganesh Bakshi, Dr. Bijoy Abraham, Dr. Kshitij Joshi, Dr. JP Agarwal, and Dr. Shishir Shetty. Over to you, Kumar.
अरे सर है ना सर इसमें एंजालुटामाइड विद रेडियोथेरेपी तो करना पड़ेगा ना सर नहीं नहीं सर किसी समवन्स फोन इज हियर So good afternoon everyone, and at the outset thank the organizers, especially Dr. Parikh sir, for this opportunity. So my job is today enzalutamide and what is the real world, how it works and what we do. So we'll start with all the situations, and prostate is a bit complicated. Maybe we are all of similar age years, most of them all younger than me, so it is a bit tricky one, but having said that, I can ask this question. Shishir, did you think that in prostate cancer 20 years back you will have a hormonal therapy after hormonal therapy and chemotherapy after all this therapy, and you will have multiple chemotherapy working in prostate cancer?
20 years back, the presentation of prostate cancer itself was different. Okay. And what we are seeing now is very different. But definitely, I never thought that therapies will change so much.
Correct.
And we
so
got options,
so
quite a lot of options.
That's why we are from the same age group.
I think, but we should think that science is going to move on.
Yeah, I agree.
Whatever 20 years back, we were of the firm belief that India has very less incidence of prostate cancer.
True. That also has changed. That also is true. Yes, sir, you wanted to say.
Yeah. When we started our own, there was only one treatment modality. That was orchidectomy. If that patient didn't agree to it, we used to give stilbestrol, 1 milligram TDS.
You used to give, sorry, what?
Stilbestrol.
Oh, stilbestrol, yes, that is true.
Okay. And at time in the mid-80s when I was training, it was said, okay, in time to come, there will be only medicines for the prostate, whether it be for BPH or for prostate cancer. And we are progressing towards that. In the near to come, there will be growth factors, against factors, which is going to be injectable, and therefore it will all switch over to our colleagues. We will be left with doing trauma and probably something else.
No, wo to nahi hoga, sir. I'll come to that question later. Sir, anytime? Oh, no, I forgot. We have a senior colleague.
So longevity has increased, perspectives will change, things will change, and demographics are changing. So it's a matter of progress, I think. It's a good progress.
So I'll tell you, I had never thought when I was doing DM, prostate was chemo-resistant tumor, and that was taught that way. That is chemo-resistant tumor. Chemotherapy doesn't work in prostate cancer. That was the teaching. We used to call it not cassette-resistant prostate cancer. We used to call hormone-resistant prostate cancer, because once you have given hormone therapy will work, and will work so well that you have 10%, 15% absolute improvement in survival. That we have never thought of, but looks like that's the way it is. We heard that science keeps changing, and we learn that not necessarily what is true today will remain true subsequently. So that is a bit about what we had seen in the past. So my topic is enzalutamide, and this is one of them, those again, hormonal therapy. After giving hormonal therapy, and it started with what we call this one, and that was when you had some data that you give hormonal therapy, you have patients becomes what we call that time hormone resistant prostate cancer, and then you give chemotherapy. Docetaxel was a buzzword that time, but we thought that 2 or 3 months improvement in survival, maybe we are stuck with it. Looks like it is not moving, and that time that's what we used to talk about. Most of the patients do not take it, docetaxel after those ADT. And then we had this drug, but asking anyone, this was what the data was there, but same time we have all these options now. So Rohit, maybe we'll start from you. In these patients who had taken hormonal therapy, progressed on chemotherapy, which one you may choose, or is there any choices today, or you think there is a enzalutamide is the default choice?
No, there is an argument to be made for each and every one of them, but the logical next step is either enzalutamide or abiraterone usually.
And
is in my
enzalutamide or abiraterone.
Yeah.
Okay.
That is what I think.
Chitiz?
Yeah, I agree with panelist. So the thing is that it is a simple treatment without much side effect. Enzalutamide or abiraterone giving which a very good result, very good radiological PFS with enzalutamide. So definitely, with some exception that we are doing for PARP inhibitors, and we use enzalutamide and abiraterone.
Bharat?
So what we have learned that in a lifespan of a prostate cancer patient, we have to use all these agents very judiciously. Either one after the other, see the patient's preference. And now what we are seeing after Karim Fazazi's presentation this year, he is trying to get all the agents upfront so that to get the maximum survival advantage. So it is good to see, the agents are coming up, upfront and upfront. So, and we have to accept the change. We are seeing those good numbers. So if the patient has used chemotherapy, you have to make assessment of the patients, as your team is only doing a very great work in geriatric thing, and most of these patients are geriatric patients. You have to assess the patients, get to the scores, and you have to decide which agents you are going to use. I think that is very important, rather than just ruling out the patient is old and not to treat with chemotherapy or these agents. I think that assessment is probably very important rather than what we choose.
Okay. So Bharat brought up an important point that many of treatment I have mentioned that has moved a bit far before, and that complicates the things further. We'll come to that once we talk about those options, and then what will be the options in this situation. Dr. Ritu is having her cake, and your comment, ma'am, because you are supposed to be in panel. Very quietly, madam has not come. No, Acho, sorry, just saw the name, that's the reason. Correct, na? Yeah, correct. Participant panel, that's okay. So, idea is that what I was trying to bring out that in a patients who have got prostate cancer, you have given hormonal therapy, you given chemotherapy, you not only have one option, you have multiple options today, and hormonal therapy options, at least out of these, two of them can move beforehand as compared in these situations. So we'll come to that questions once we have the data regarding enzalutamide, but we'll stick to enzalutamide. So coming to subsequently, this was the data for enzalutamide because what we call ARB7 mutation, and again asking people, do we do it? Rohit?
No.
No. Chetiz? No. Bharat? Anyone? Dr. Shishir? Dr. Ganesh, sir?
I don't think we but if I go to Kumar, the previous one.
Yes, sir.
See, as I think Bharat also said, we will have a geriatric issues.
Yes, sir.
We will have some comorbidities. And depending upon the drugs they are taking for their comorbidities, we should be choosing the first or the second one. I think because some profile of a fall or etc. is more common with one drug rather than the other drug. Am I right?
Yes, sir.
So I think we should be really talking to the patient in depth, what drugs they are taking, and then we should be deciding that which one we should be offering.
I agree with you, sir. The only problem is that Bharat may say, Kumar, I have used enzalutamide in hormone sensitive situation. Now what do I do? That's why I have left it there because the question will come later, but because you commented, sir, we thought maybe that will be a good discussion.
According to the study which he was quoting, which is called the Peace Trial, which has come out from France, according to that, is basically a European trial. Okay, they say upfront all three treatments together, which is combination of androgen, either this thing, what you call orchidectomy,
Yes.
or medical orchidectomy,
Yes.
plus cabazitaxel plus abiraterone or enzalutamide.
Yes.
These three combined together, they stopped the recruitment because the survival advantage was so much
Yes.
that there was no need to further complete the study. This was the phase 3 study, enough in recruitment and completed in Europe.
I agree with that. I agree with you, and that complicates this, sir. Now the choices become tougher, sir.
Yes, it does become tougher, but when there is the writing on the wall which has shown so much of difference,
We
why
should
not
be
use it?
okay. We'll come to that question because that situation will be there. We thought because it was enzalutamide, so we'll start from the where it started from. But we'll come to that question, and this will be important question, and we'll come to Dr. JP sir also what he thinks about it at that time. Coming to this testing, so again, excellent paper in NAGM, and what you heard, no one does it. Anyone in the audience does it? ARV7? By and large, we don't. And one of the problem is that this test is tough to do. Somehow this mutation, it has been a problem to do in best of the hand. And that's the reason, in spite of good data, by and large, this mutation is not done. So we leave it there.
But if you have a report of this mutation on your table,
Oh, very good.
would it change your practice?
Anyone can take it. If you have this mutation,
Then I think logically we should not use that molecule because it is said to work less. And I had inquired once about 2-3 years back about ARV7 in India. No one does. In abroad also, even in the US situations, they don't do it. It's there in study settings in most of the places.
Yeah,
That is how they mobilize ARV7.
I agree with you. There is a problem with this, the mutations, the way they are, there is a technology issue because same, Dr. Ganesh, I also was inquiring about it because we wanted to put in our panel and then we realized that there is a problem in doing this test. But what your question is valid, and I take this question back to Dr. Rohit. Report is there, ARV7 mutation positive. Does it make a difference in your decision?
So if there is a report, I would perhaps not use the resistant agent, the androgen targeting agents.
So the point that's coming out is this mutation is important. We know it could change the way we treat. It is predictive. But because of the testing modality and the difficulty, we are not advocating. Is that the take-home message?
So I'll tell you.
Or is it that it is not of use in the general population?
So I have a small point actually. I mean, you all prescribe abiraterone and enzalutamide nowadays.
True.
And you know, in a select percentage of patients, you do see that they don't work.
They don't work. That is true.
So probably we should hypothesize that this is present.
I understand, but my question was
Reverse.
Maybe the issue is with the testing, sir. I think ARV7,
Okay.
if there was a valid test, maybe we can use it.
Bharat, any comment? Report is there. Will you change your decision and some reasoning for it?
Most of the time, whenever we come across such situation, somebody has done already and come to you with the report. Then whatever literature we have is this only. So in that patient, if I use chemotherapy, that is also right. If no, and now if you have a report, I would tend to use the chemotherapy. That's it. That is why my take is.
So there are two ways to look for it. One is that it's a bit not like EGFR, where negative predictive value is almost 99%. Means that EGFR mutation is negative, TKI works in only 1%. This is not that kind of a biomarker, at least proven multiple times. Initial NAGM paper was absolutely excellent and everyone thought, I was also thought, oh, this is going to come in next few months, and I used to be after Santosh to why you are not including in the testing. But it has not happened that way. It is a negative predictive marker that a patient do badly, but not as good a biomarker like EGFR. Otherwise, we would have been after it and somehow this would have been the market. And second is that you have good alternatives. So enzalutamide doesn't work, abiraterone doesn't work, you have docetaxel, you have cabazitaxel, so you have multiple options, so one can. So what you're suggesting that if the report is there, will you change it? Say why not? And in the Prostate, you always have third, fourth, fifth line. And you know, at that time, sure, one can use it. So that's way my interpretation will be there.
If this patient, suppose the report is there positive and we use chemotherapy and the patient progresses. So is it only the sequence changes, chemotherapy followed by the androgen agents or androgen agent followed by chemotherapy? That answer we don't have in a clinical trial.
Yeah. So leaving out is that answer we
Dr.
don't have.
Kumar,
Yes, go ahead.
Unlike other cancers, in prostate cancer, if some drug is not working for 2-3 months, you wait, there's nothing going to go wrong with the patient. Yeah?
So,
we can safely wait in prostate cancer, unlike other cancers
So
where
I
things
think
may
so.
go wrong.
What his question is that this biomarker,
If
what,
it is
what
there,
does your
great. If it
decision
is
making?
not there, Ganesh is suggesting is what all of us do. We give a trial. If it is working good, if it is not, you change over.
Correct. So I totally agree with you. But with the catch, for example, if you have a BRCA mutation, negative, you don't use PARP inhibitor because your negative predictive value is almost 99, 100% in prostate cancer. Again, there's a debate. That debate can happen this doesn't happen in breast cancer. No, not necessarily. But if you, that's where your biomarker decides in a different way. Here it is like you change your sequence because you have alternative. Otherwise, this biomarker today doesn't obviates completely the use of this drug. Any other? Go ahead. Go ahead.
It's that daughter-in-law syndrome we are talking about. There is a daughter-in-law syndrome, from US, who would probably read up all the literature that is available and task us doctors in India about why this was not done.
Okay.
So that's what is the medical legal issue.
Last week I had a patient, the patient relative told me, and prostate cancer, unless you have done AR test, how can you give
so that's
ADT?
a problem.
So I said कि नहीं दे सकते, बोला ना, उन्होंने डॉक्टर साहब ने यूएस में बोला हुआ है बिना जब तक AR रिसेप्टर की टेस्ट नहीं होगी तब तक आप नहीं दे सकते. मैं बोला साहब आपकी मर्जी है.
On the similar lines, we are trying to be very safe with the drugs. Like audiometry, you started, no, and we all are following. Even for DPD, we are trying to get. So those, it is still not a standard of care in all the centers. But we know the consequences if something goes wrong. Then if you have a report, you have to act according to the literature. You can't apply your mind.
Agree. I totally agree with you. So you have a report, you need to act upon it. So coming to the second situation, this was the first situation. You had hormone sensitive prostate cancer. You have given hormonal therapy. You have given chemotherapy. Then what we do with enzalutamide. Second one is that you have not given chemotherapy, and then the patient is castrate-resistant prostate cancer. Does the choices change? Bharat, maybe we'll start from.
So, so far, fortunately, we have all these agents. 10-15 years back, when I was with you, we used to look for Honovan kahan pe milta hai. But that was the only thing which was available then, beyond chemotherapy or mitoxantrone. Yeah. So again, the take is same. I usually see what agents previously been used and what was the depth of response and what was the longevity of the response, whether I can re-challenge those agents. My intention is only thing, we have to place all these agents one after the other based on the patient's profile and get maximum outcome in terms of overall survival with a good quality of life. So I have couple of time I have been fortunate to use almost all the therapies except PARP inhibitors and very rarely cabazitaxel.
Rarely cabazitaxel. Okay. Cabazitaxel ever? No.
Dangerous drug.
Well,
Yes.
this is the classic, the Prosper study. Prosper study is, of course, the use of.
We'll come to that. So Prosper is also there. We will come to the Prosper also. Chitis, any comment, any choices, any specific choice you have, and the reason?
So we are talking about a condition where it progresses over the hormonal therapy process.
Hormonal therapy, ADT given, now is the CRPC, but chemo naive.
Chemo naive, and it is no visceral disease as such.
That's right. Which one and where you will choose?
Yeah, if
So
visceral
good. So
disease, the
you're saying you will
chemotherapy.
select it accordingly, some parameter. Go ahead.
Yeah, then chemotherapy. Otherwise, I am comfortably using this enzalutamide or abiraterone. So
Okay. So go ahead, sir. Go ahead, sir.
See, I think classical teaching patient factors, the tumor factors, and sorry. So I think you all use these drugs in some combination or this, that. See, it depends upon the patient factors, where exactly tumor, visceral, is it very aggressive? On the basis of those, you make a decision which one to go in what sequence. I think that's, though I'm a local guy, but common sense says to me, and that's what I think people does it, right? So we should be using upon so many factors, but the sequence may change.
Yes, sir, that's what Chitu was trying to say. The factors which will help us Yeah, Bharat, go ahead. You wanted
Exactly
to add?
same thing. The assessment again, no radiological assessment. We don't only rely on the PSA profile, where I think largely everybody has moved towards using enzalutamide or abiraterone if the patient is not symptomatic, only bone disease, where it can be taken care of. Symptoms can be taken care by using radiation also over there. Important thing. Even for oligometastatic side, we are coming with the data. You have excellent response with the systemic therapy. Use local radiation, and you can consolidate it as translate into survival. So now it is a time to discuss in detail in MDT, prostate cancer, and give a patient chart that this is your future is going to be. And that is, I think, one of the biomarker, key biomarker, MDT decision, considering, taking into consideration the nuclear physician's opinion also. And ultimately it is going to help the patient. So if somebody is using enzalutamide abiraterone, patient is not grossly symptomatic, not using too many drugs, ECG is okay, using these oral agents is the best thing. Patient yesterday, last week I have a patient who presented to a GI with a constipation, severe constipation, and there was a prostate tumor going into the rectum. And now this profile I would consider for chemotherapy, not will go for upfront. Immediately orchidectomy, go take the patients for chemotherapy, because here I want a rapid response. And
Okay. Any local treatment, CRPC anytime? Ganesh or Dr. Shishir?
Technically, no role for such a radical local therapy.
Okay.
Palliative local therapy.
Yes. Never
DYP
forget,
or
whole
something
lot of people require. Yeah,
would
correct.
require.
Totally. Sir, again,
So I had
I have not generalized statement, but we have seen the biology of the disease very indolent, though it is metastatic. Patient had responded fantastically to ADT and oral agents, and lived for beyond a couple of years. And then a local tumor is troubling. In that case, after doing a joint meeting, we have done this. Not for all patients, but we have done this, and patients are still doing good. They get to know these all long-term complications when they survive with the local therapy, but ultimately, patient wants survival also as
I take your point. So I also totally agree. As we learn, as the patient starts living longer, multiple other treatments keeps coming back. And that's what I was coming to in the statement that it will be not only those tablets and injections. I've seen in lung cancer, you have a stage 4 patients, local treatment used to think, where used to give in lung cancer stage 4 local treatment. Now every patient of EGFR mutation positive or ALK, if they progress, first thing you want to do, can you give local treatment? Is there oligo-progressive disease? And then you obviate the need of changing the TKI. So I agree that we will have those scenarios apart from the palliative treatment what we give. If not, then we move on to the next situation, that is hormone sensitive prostate cancer, which sir was alluding to, that the patient comes first time, metastatic disease, hormone sensitive prostate cancer, and then you have all kinds of options available. And then how do you choose? Maybe we'll start with Dr. JP sir. Sir, local treatment. That's why I put RT is not there. I'm surprised.
No. So it is
I had put मैं miss कर गया. Yes.
No, it is not like that. That's what I think.
Oligometastatic disease, sir. Does it,
So
do you want to give RT, and then when and how and which group of those patients?
So definitely the people will start with a systemic, but if there are local symptoms, I think we should be offering them local treatment. And at some point of time, or if they are progressing locally on a systemic treatment, we should be offering at that point of time. The dose per fraction, and the overall time period may change person to person, but some point of time local may be offered in a select group of patients.
Okay. And any criteria?
Any progression, whatever you see.
Any progression. Upfront, anyone?
Very uncommon.
Very
uncommonly. Really.
Any local treatments?
I have not, though this is not my bread and butter, that's what I told. But no, I don't think we generally don't offer upfront very sensitive ones. People have always given some form of ADT and then given.
Then done it, but not waiting for progression.
Yeah, I don't think so.
So any local treatment? We'll come to right.
Next.
Sir.
Local treatment
In form of surgery or radiotherapy?
No, I think I would prefer definitely radiation.
Okay.
Because obviously, there's giving a local treatment in the form of, I mean, if it's for obstructive symptoms channeling,
Okay.
that's going to come back.
Okay.
So I want something which probably along with the ADT plus maybe some other medication, maybe just to, for the local symptoms, yes, radiation would be
Okay.
it.
Coming to Dr. Ganesh and Dr. Shishir, oligometastatic disease.
So oligometastatic disease, the HORADs and the STAMPEDE have had data with giving local therapy in these, and probably
With conjunction of systemic,
with systemic. So in India we have a plus point that we do PSMA PET CTs. So probably our criteria of oligomets was quite more stringent, or is rather more stringent than what has been recorded in the STAMPEDE data. They were by the bone scan. What we used to follow at TMH was we used to start probably on ADT plus abiraterone, and where people used to give local therapy at something like 2 to 3 months, we used to still see a response assessment at 5 to 6 months. Consider it a sustained thing, see the response that it is going down, and give local plus SOS, or if possible give MDT also, metastasis directed. Surgeries we have not done, and because
But
they have
you
not been
tempted to?
recommended right now, but people have been doing in India, a few of them. On the verbal talk, they said that 50-60% patients have progressed further, remaining are okay.
So looks like there is a tantalizing role
I
of
have,
local treatment.
In oligometastatic, if you look at it, RT to the prostate is a consensus. We do it. Yes.
Yes, we have been doing it for a good time.
No, I think we should be doing it because there is enough data from the STAMPEDE that in at least the less than 4 metastatic site, if it is there, the primary prostate radiation helps.
And many of these patients are doing well.
Yeah, for the metastatic directed is the only controversy, and radiotherapy has some data. The Oriole and the Stomp and the Oriole. And the Oriole.
Patients are doing well. I mean,
Yeah, for the surgery, no. There is a trial ongoing. People do think they can operate the metastasis, but I don't think there is enough evidence.
So idea was to have a oligometastatic disease and treat them bit differently, have the local treatment as a part of decision making. And your question of the not treating the Mets, there is a valid reason for it, because that was the trial. It was a subgroup analysis which suggested that in those patient with low volume disease there was a benefit, and that's the reason this discussion is coming up.
But the Oriole was specifically done, and the Stomp was specifically done for these subgroup of patients.
For low volume separate?
No, for the metastatic directed therapy.
Yes, so if I remember, if the same name is there, I'm forgetting the name. That trial was negative trial. The positive was part of the low volume disease where the outcome was positive. I think so. Dr. JP and someone else can, or Dr. Nagaraj can help me out. Go ahead. Yes, ma'am. Yeah.
Prostate,
Yes,
wherein there is a definite role of what Dr. Sahoo is talking, that we do give metastatic directed therapy. And then in case of metastatic presentation,
Give RT to the prostate.
RT to the prostate,
Yes,
which is STAMPEDE trial.
Okay. And that, ma'am, the first one what you're saying is the overall trial was positive, or it was positive for low volume disease?
It is definitely for low volume. It
low-risk
is
was
less than
subgroup.
5.
It was overall, it was negative.
It is less than 5 metastatic deposits, wherein the STORM trial is showing even overall survival benefit.
Again, subgroup, ma'am.
Subgroup.
Not the overall yet. Overall, it was, so that was and based on that, NCCN has it. I totally concede. I'm not saying that's not an option there, and that's the reason I brought it up, that we should know that yes, it is an option there, but I'm saying where the data came from, it was a part of a subgroup analysis, and we should know that this option is there, and one should consider it for low volume disease, metastatic in prostate cancer. Perfectly fine. So at least we know that, we understand that it should be done. What do we do with these tablets and injections? Yeah, go ahead.
So one more important point just to add to this controversy was, in the STAMPEDE data it was only ADT.
Correct, yes.
Exactly.
So today, since the standard of SOC is ADT plus something, I still feel, and I am very strong for that, we should give ADT plus
something plus something, and something plus something we'll talk about.
Because if we talk about simple abiraterone, although the topic is enzalutamide,
yes,
then it's again a very strong data that there are partial or complete responses being seen with it.
With them. Okay.
Vis-a-vis, say I'm doing surgery and there is a data about enzalutamide used prior to surgery. 50 patients odd, so 3 have got CR and remaining not hardly anything. So minimal residual.
So the question is, if you use a lot of systemic disease, every treatment has some, if whatever local we give will have some side effects. So you need to balance both, If you are aggressive, very systemic, ADT and local is fine, right? But if you add so many things and then expect a local to give a big benefit, it is, because if you use extreme hypofractionation, you are likely to have some side effects, strictures and all those things.
So I'll give you an analogy, sir. I agree with you, sir. I'm saying that every treatment, when we combine, what we are doing, it gives you the result, what outcome happens. Lung cancer, oligometastatic disease, there is not 3 randomized trial that if you give RT in them, the benefit is there. In fact, all the out of those 2 of them, one of them was lung as a part of it, other 2 were dedicated lung. Trial was stopped by DSMC because of the kind of benefit they say. Do we use it? We don't. Why, what is the reason? Reason is, the problem is that the trial was done with a gefitinib. Now we have osimertinib. The problem is that you have a 20-month survival. Now it is a 40-month survival. With RT you add, you get 25 months. So, whatever treatment we develop, here is just the systemic therapy, sir. I'm expert. My knowledge is for systemic therapy, so I'm giving example. Reverse. If RT gives a better result, then systemic therapy has to compete with it, and vice versa. So, as in lung, in metastatic prostate cancer, the problem is that we never thought that we'll have this systemic therapy. Somehow, systemic therapy started changing things really differently, and then RT, if they want to say that, hey, it works far better, they have to compete with them to say, hey, not only we work better, with whatever you give, then also it adds life to the patient. So, so your point is well taken, sir, but then in that scenario, one has to prove it for any modality. So, coming back to systemic therapy, here, which one to choose? ADT, absolutely everyone agrees. Any doubt about adding enzalutamide, abiraterone, docetaxel, and if you choose, which one to add? Rohit.
So,
or out of those, you can choose any one of them.
So, anyone can be chosen, quite frankly. You have data with darolutamide also now. I think that trial is also positive. But if there is a high volume disease, then chemotherapy, there is a strong argument for chemotherapy. And with the piece 1 data, we can add abiraterone in a high volume patient, because most of the survival benefit in that trial was also driven by high volume disease patients. So that is my opinion. So high volume disease, chemotherapy, I would strongly consider, charted definition, standard, and if at all the patient is fit enough, I would definitely add abiraterone. And I would like to have a look at the liver enzymes and other things, because the toxicity is something which I would be concerned about, but in a high volume disease patient, as of now, I would consider dosi plus abiraterone.
Kshitij, anyone, any specific choices?
No, I agree with him. Only thing is that there are many different points on the basis of which we take decision. Like he has suggested high volume disease. At the same time, we are dealing with very elderly population having cardiac problems, and we have to take in diabetic, severe diabetic, we have to take each and every factor in play, this consideration. Third thing is that whenever possible, if the patient may be fit afferent for any chemotherapy, he may not be fit in future. Also, there is a survival advantage with afferent chemotherapy. So, whenever patient is fit and having high volume disease, docetaxel chemotherapy can be considered, and we have a low dose reduction like a bi-weekly regime with 50 milligram per meter square as well, so that he can tolerate. And suppose the patient is not fit enough and very low volume disease, then abiraterone and enzalutamide both are equal options. If the cardiac complications are there, I will avoid abiraterone, I will prefer enzalutamide, and also diabetic, I will prefer enzalutamide. Otherwise, both are okay.
Thank you. Yeah, go ahead, sir.
In this patient group, if you're talking of elderly patients, 80 plus and above, obviously you can come down on the dose of enzalutamide. You don't have to give 160.
160,
You
yeah.
can give 80. It has not shown any survival disadvantage. In fact, it is the same survival. So to cut down on the toxicity, which is in this age group, you probably have a lot of weakness. That, of course, can be cut down by cutting down the dosage without affecting the survival.
Okay. Thank you. Bharat,
So
anyone,
all the-
patients, only ADT, and another patient, anyone choosing docetaxel hypodarolutamide, but as sir said, there is a trial also for abiraterone or enzalutamide. So 3 drugs for anyone and only
we
1 drug for
started with
anyone?
the- Yeah, so I started with the DAD discussion. So all 3, you know,
All
now
3,
maybe in a year's time we'll be using all 3 drugs together. But all the first 3 options are accurate, and no, then it is your perspective. Now we started with the stocks discussion in the beginning. Purvish sir is busy in, I think, so FOMO is, there is always idea of no FOMO. Here you also fear of missing out that patient. So use the chemotherapy first, use our best weapon so that no patient remain compliant. For tablets, in India, it is no, compliance is a big challenge. You write a tablet, patient goes to other person, he will say chemotherapy. So you have to assess the patient again, what is going on in the patient's mind. We also have to see what are the patient's expectation out of it. So we have to spend time with the patient, and that, so.
So I'm putting, no one is willing to take it, sir. I deliberately
So,
I put it, sir.
so-
Ki someone should say,
So I
sometimes
said in the signal, I said I have used all those options, including except the PARP inhibitor and cabazitaxel, rarely. So in that, I think
yes.
so
where
there
do
was a
you use-
data presented and people claimed no survival. Unfortunately, no.
CRP,
We have, yeah. So we have to use all those effective therapies.
So what sir is commenting, ki no one is picking up PSMA ever. So I said ki I have put it from the beginning.
So the problem over here, so the phobia for us, once we use upfront all these therapies, to use systemic therapies which have no myelosuppressive effect, that gets exaggerated. Then you end up, that is what I said, fear of missing out. Once you use this agent, you will not be able to use all these other agents subsequently. After lutetium, I do understand there are that is why
It is a
limited
problem.
access. Yeah, it's a problem.
It's a problem. So PSMA, lutetium, that data is very intriguing and also very revealing. So first was efficacy part. We had not thought that radioisotope based therapy can be so effective, and it's really very effective. 49% patient having a response, and that is resist. That is something in 3rd line that we have and large not seen. So that is very striking. But this very striking part of side effects, we had not thought that PSMA lutetium based therapy can have so much of neutropenia. So if you give lutetium PSMA therapy, what we had thought, that majority of them doesn't get trouble. I think so 30 or 40% patient had severe neutropenia, which we had not expected. So both way it was striking. But again, not for hormone sensitive prostate cancer, primarily for CRPC, as Dr. Bharat said, and that too after failing at least 1 treatment. That is where it was used.
Again,
go ahead, sir.
I come down to very basic. So it will be dependent upon the physician commonly using it. Excess of lutetium is not so easy, sir.
Yes.
In a second town, it is not so easy. The handling of neutropenia, if it happens, and it's a prolonged neutropenia, it is not like you take care of a 7 days, he comes out. And if it happens in elderly, it is much more multi-organ challenges happen. So what I'm trying to say again,
what is available and what we are comfortable with. So just one comment which was made by him was important, that what we have seen with docetaxel, you get absolute improvement in survival of around 13-14% as compared to ADT alone in hormone sensitive prostate cancer. Add darolutamide to it, it adds again 12-13%. That is striking in prostate cancer. So because the comparison with ADT with docetaxel is there, so you don't have comparison of ADT versus ADT plus docetaxel plus darolutamide. So indirectly something improving, absolute improvement in survival by 20%, 25% odd, no, so which we had not thought of it. This was prosper, and there was a discussion regarding this. Non-metastatic no, CRPC, you don't have a METS, PSA goes up. Do you want to treat, and want to treat with what, sir? Anything? All three? Any option? So non-metastatic but CRPC. PSA is up, no symptoms. Still treat. So yes, almost 50% patients, they die at 5 years if you don't treat them. So as much it looks asymptomatic, remember, and half of them is because of disease. So it's you need to consider treating. An option, as you suggested, there are 3 drugs: enzalutamide, abiraterone, darolutamide. Darolutamide is not available in India. One can choose one of them, but that's a problem. We have only 1 minute, so a bit about dosing.
Darolutamide is far better than that of
Absolutely. It doesn't trouble, the CNS symptoms are not there, so easy to give. So Bharat, question, dose, comfortable?
Yeah, so basically for fit patients who are not on too many medications, better to use this dose.
This dose.
But for enzalutamide, we have to see what are the inducer, what are the inhibitor, then decide the dose.
I'll come to that.
Challenge with the enzalutamide.
So I'll come to that. Dose modification, how many times you have to do it and how careful you need to be? 10 seconds, because we have 30 seconds and 2 more slides.
So in my experience, almost 30-40% required dose modification, and I have done 280 milligram dose, and they are doing quite well on 80 with a very significant reduction in PSA, but 50-60% tolerated.
Okay. Rohit, for concomitant medication, should we get worried when we give enzalutamide?
Yeah, drug interactions we need to check, definitely.
And dose adjustment, in generic we should remember this, otherwise have a chart in your clinic, otherwise remember this dose modification, but especially for kidney and liver, it is safe as compared to what we see with abiraterone.
Initially given 4 times and now 1 time.
Sorry, sir?
Initially I think you used to give enzalutamide 4 times a day, right? No, it was always once a day. I don't know, I thought I was curious.
Okay. No, ODs. We have
It
given
was always once a day?
ODs only, sir. I think so. We had a 40 milligram tablet, so it should become a trouble. Now I think so. BDR is supposedly having 160 milligram tablet, so you have a choice. One can use only single tablet, so that makes life easier. But otherwise, OD, sir. Yeah. Any last comment by anyone?
Well, there is the new study which is coming out to reduce the development of, the mutations so that, the drug remains effective for long. It is called bipolar aneurysm therapy. It's being used in the West, wherein this is after the development of the thing. It is along with olaparib therapy.
Okay. Okay.
Okay, because the patient has had ADT, but probably every month, just to increase the sensitivity, they give a 400 milligram injection subcutaneously of testosterone.
Okay. Any other comment by anyone?
So
any last comment?
in
Yes,
the
last
era,
comment.
I want to ask a question, which is little different from the science. What anybody has re-challenged enzalutamide?
Enzalutamide. Anyone has re-challenged?
Next phase.
I have re-challenged, but not with enzalutamide.
Abiraterone.
No, I have re-challenged with where I have switched over to extend.
Oh, okay. Okay. So given some, so I have not re-challenged. I have changed it. Initially, I used to think that if you give abiraterone, enzalutamide doesn't work, and vice versa. But I don't think that's absolutely true. There are some patients, but usually they don't.
Probably enough, publications which say it doesn't affect, and there are publications which say it does.
It does affect.
So still the final word is not out on it, but we will progress to other drugs.
Thank you. Bharat, any last comment?
so in the era of immunotherapy and targeted therapy and precision oncology, for prostate cancer, from Advani sir is there. So when the patient follows with you for years, you need not treat the reports. Nowadays we get lot many fancy reports. You have to treat the patient. That is very, very important for prostate cancer. You see, sometimes re-challenging based on your experience also better decision rather than treating a report which we get today.
Correct, because I was looking for someone to say ADT in some patients. So what you said is right. There are patients where only ADT is good enough. Sir, yes, sir.
Yeah, I wanted to make a comment.
Yes, sir.
In the previous, when we had the S1 discussion, No, that's a drug which again is metabolized through CYP3A, this thing enzyme. This drug is also metabolized through same thing. There everyone was talking, where is Indian data, where is Indian data, we need Indian data. Was there Indian data when this drug came in the market? Because this also, I'm on the DCJ, so I know this drug was also this thing, Arches trial, which was the original pivotal trial, no Indian patients were there. On the contrary, no, hardly any Japanese or this thing patients were on the original trial. Still it came in the market, not single person, even today talked about Indian data. Why are we having two different, this thing, if you have not asked for Indian data when you started using this, why do you need for S1, So, I mean, it's the same mechanism. So what I'm telling is the way we approve drugs, we'll talk about it in the next this thing, but we don't have, most of the drugs which come in Indian market do not have Indian data when it comes. We do a phase 4 trial just to get some information. But, these drugs, and it's as per the law. So change the law and all, and then like the Japanese market needs every drug to have a Japanese phase 3 trial. If you change that, it's okay. But when there's no such, law in India, we bring it in the market and do, but there are two different. I was seeing that. Not one person talked about Indian data or whether the somebody asked how many tolerate, but overall we never questioned it when it came.
Sir, I totally agree with you, and my 2 cents about it. Yes, except United States, Europe, Japan, and now China, where they start pushing that trial should be done at that place for drug to be approved, and that's because of they have the capacity, and we don't have. That's a fact of life. We don't have. I totally agree. So there's a bias where it has come from. What we are forgetting in all this is that we had around white man syndrome from west. If we don't start working here, we will have a white man syndrome from east. Most of the drug is going from China. Take all immunotherapy developed after the initial 5 of them. For immunotherapy, all the data is from China. And the China, Chinese data, LILD didn't get a FDA label. But they are planning to market in Asia, and they will be marketing. It will be cheaper. Then again, but I repeat that, white man syndrome from east, unless we start working here. So I think so problem lies with us to work. But I totally agree with you, sir. What you said is right. That questions was not asked, and our bias also gets reflected. Thank you, sir. Thank you. I thank the audience and the panels.
Thank you very much, and we move to the last panel for the scientific part for today. Chairperson Dr. Purna Kurkure, the moderator Dr. TP Sahoo, and the panelists Dr. Amol Patel, Dr. NN Prem, Dr. Anjana Sainani, Dr. Amol Akhade, and Dr. Shripad Banal. Over to you, madam.
Yeah, you have to start.
Good afternoon.
I missed out.
It is almost good evening, and we are at the last session, but it is a very interesting title of fixed dose versus weight-based dosing in oncology, the cost-effective strategy. As we know, conventionally, chemotherapy is always weight-based and at times surface area based. But in children, I am a pediatric oncologist, and we give so much of importance to weight-based chemotherapy because every decimal counts, as we say. In obese patients, adult patients also, American Society of Clinical Oncology has said that we should go by the weight, and there should not be any reduction because the patient is obese. And those recommendations are well known if you want to see the effect of chemotherapy. So the first examples of a fixed dose was weight-based, that is vincristine, vinblastine, if you go historically. It is weight-based but fixed for the upper dose, upper limit. Now we have moved on from chemotherapy to many of these small molecules and antibodies, where the pharmacokinetics and distribution and elimination is not by organs but by many other mechanisms, and that is how, and they are quite costly. So there comes the question of cost benefit discussion for such molecules. So it will be very interesting to see the whole spectrum moving on from weight based to now fixed dose and the calculations of cost effectiveness. I invite Dr. Sahoo to take into this
Thank you, ma'am.
discussion.
Thank you, ma'am, and thanks, Dr. Parekh, for the invite. I think, yeah. So we'll have a very different type of discussion here, and I think this is very important, particularly in pertinence to the country where we practice and which we belong to. So I'll start off with sir. Sir, fixed dose versus weight-based, two important advantages and disadvantages for either of them.
You know, I'll make a disclaimer to begin with. Today's this thing I have come not to talk about this because there are two Amols who have done a lot of work on that. I have come, accepted this invitation because I wanted to tell them the DCJ, you know, what are the, you know, the governmental rules and this thing and why, because they keep on writing on that. Unfortunately, you know, by the time I see that there are 100, 200 messages and I have, and I have no time to answer, and if you answer, you have to come back with the reply, which I cannot do. So I thought I'll let them know what are the regulatory issues.
So we have that. We have that.
I know. So, I listen to both Amol because they worked hard on this and they've done a great job. I'll learn from this, but I'll tell the regulatory issues related to that.
So point taken, and we'll take the first Amol. Yeah, please. So weight-based and fixed dose, there are particular advantages of either of them. And just state one or two before we move on to the subject.
See, as in the introduction, madam said that for a drug like vincristine, we have a capping of the dose. So in that, even if you have a weight-based dosing, we generally in adult do not exceed at one time more than 2 milligram of dose. So even though most of our dosing regimens are generally weight-based, there are some situations in which the fixed dose is previously also advocated. Why this has become suddenly a more important issue is because of the immunotherapy drugs.
Fine.
And that is because of the cost of the drugs, and as we had pointed out that various surveys, it is seen that only 2 to 3% of our population is able to take immunotherapy drugs. And hence this entire discussion has started whether we should allow a weight-based dosing in immunotherapy drugs along with the fixed schedule.
Okay, so basic thing is that the fixed and the weight dose is basically in a person who is has a high BSA. When you do a fixed dose, it might be underdosing it, and when you are having a patient who's very thin with a fixed dose, you might be overdosing it. So that concept definitely lies a fixed dose. While in the weight based, this thing really goes away. That's a very important thing that has been highlighted in literature. But most important thing which is not beyond, I'll ask my geriatrician. I don't have specific questions for the geriatrics part. I'm sorry for that. But only thing I have to tell you, one point here is this: if you look into the BSA part of it, we have capped the BSA at 2 normally. But if you go into literature, there's nothing as the capping at 2, and even they have found that you should correlate the BSA with the BMI. And both these things should correlate while we dose it. It's for some other day, but that thing was so interlinked, I thought I'll bring this into important. I'm just going to cut this because it is the last topic. We'll go into the specific thing why we both Amols are here, and then we'll discuss the whole point because this is so pertinent to our to India. Just a very important thing. I didn't know this. I learned when I went through carboplatin. What would be the highest GFR cap? Because if you calculate GFR, you cap it at something.
125.
125.
And it goes to 900 milligrams.
Yeah.
So when you go to practice, we have used 900 milligram, you know, at maximum. But by seeing the patient like a soldier, he comes with the, you know, physically fit, 20
Yes, that
years.
exactly.
That exactly. And you can't use in a PS3 borderline with a creatinine 0.3
and we
with a
don't do a
ladies.
creatinine below 7. So let's come to the case and we take the immuno-oncology part in the things. Elderly male, PDL1 of 60% with advanced NSCLC, a weight of 70 kg. Very clear? I don't think we need any more data on this. What do we do? And we have all these options and anything which you want to do, I will read it for all of it. Pembrolizumab 200 milligrams flat dose 3 weeks, which is the approved indication. I want to state it very clearly. Pembrolizumab 2 milligram per kg once every 3 weeks. Pembro 100 milligrams every 2 weeks, which is again something which we want to do, or 100 milligrams 3 weeks. So I put two different scheduling of 2 and 3 year, and I've also gone through the editorial and thought I'll put this dose also of Pembro 1 milligram per kg every 3 weeks. So I will start from the right. Can we have what would be your your regimen of choice, Dr. Anjana? Yeah.
Last two options I would not.
So you would not consider 100 milligrams, or you would not consider 1 milligram per kg also. Okay, these two options out for you.
And among us the other three, yes, the evidence-based is or whatever recommended is 200 every 3 weeks, flat dose is fair enough, because if it is recommended, you can't go wrong with it. But 2 milligram per kg every 3 weeks is what we are using generally.
Okay.
As long as patient is affording.
Okay. So you would take 1 and 2, any one of that is your choice.
And 100 milligram every 2 weeks, yes, we have sometimes tried when it comes to the question of either side effect.
For pembrolizumab, you have shortened the duration?
Shortened the duration.
2 weeks?
Sometimes if patient wants, sometimes they wish for quicker responses initially at a point.
Okay.
Not always, not a very common practice.
So I'll come to Dr. Amol Patel. First I'll come to you, the last part where she left. Do you have evidence that if you give it more frequently, you have more responses?
No.
No. As per literature, no?
Yes, we don't
okay.
have.
We'll take it at some other point.
What kind of responses you are looking in immunotherapy? Majority are stable disease.
Okay. So can you come to your choice now?
My choice is all the corner 2 milligram per kg every 3 weeks.
Okay. So
that is my choice.
Yeah, it's your choice.
See, if we are talking an ideal situation, whether it is my practice at Army Hospital R&R or my practice
what would you love to do?
I do it 2 milligram per kg.
What would you love to do? If
I would love to do 1 milligram per kg every 3 weeks.
So we have you telling that you would love to, you do it at 2 milligram per kg at this point once in 3 weeks, and not the flat dose of 200 milligrams.
Absolutely not.
Okay, and you would love to go to the last option.
Yes.
That's what. Dr. Amol, again.
Yeah, as I said, I agree with him that yes, I will give him both the options of 200 mg flat dose and 2 mg per kg every 3 weekly. If patient has financial constraints and patient decides that 2 mg per kg, because his weight is 70 kg, so that way it becomes 140. So I will give both the options, saying that 200 mg flat dose is the one that is approved as of now in India.
So if it is 50 kg, you will not give that option.
What are you saying?
Because if it's 50 kg, because 100 mg vials are there, will that option be given?
See, for 50 kg person also, current approved dose is 200 mg flat dose every 3 weekly. But if there is an option of 2 mg per kg, for 50 kg person, this dose becomes 100 mg.
Yeah.
So I will give both the options to the patient, and if there are financial constraints, the other option, if the patient decides to choose and agrees that it is not approved, but still he wants to go ahead with that, we will use that. And as Dr. Amol Patel said, yes, ideally 1 mg per kg for every 3 weekly also may work.
I'll come to a very basic question. We are dealing this in a stage 4 disease. I know that patients are going to progress, and you never know who's going to challenge you where in the court. So we have to keep our back safe. I like to sir to answer. So the recommendation as per what the Drug Control of India has given is the pembrolizumab 200 flat dose. So now I give a 2 milligrams, and I give 100 milligrams for 50 kg, and the patient progresses. How safe I am in the court of law, and what happens on the regulatory part?
So I'll tell you the regulatory issue is with this, because they keep on asking regulatory. See, regulatory DCGI does what, the trials which are registered with them for regulatory purposes. So as an individual, you cannot, or we don't. So the company, the company only registers any molecule for the dose and all as a regulatory this thing. But that doesn't prevent you from you know, this is, so what happened with all these molecules actually to begin with, the regulatory trials had per milligram per kg dose. Later they showed that basically the pharmacokinetics and all does not differ. Now again you have to take with this thing, these are American patients, 70, 80, where they showed that the pharmacokinetics with 2 milligram per kg dose is not within 6% of 2% versus, 2 milligram per kg versus 200 milligram. This thing was within the 6% difference, which is an acceptable thing for pharmacokinetics. So hence, that is the reason they got it registered or changed later to 2 milligram, from 2 milligram per kg to flat dose of 200. But you know, that is an approved, still the pivotal trial was approved at 2 milligrams. So no court of law will, see, you and I cannot go and tell that I want to register this dose, because there one time I think somebody, one of the two Amol raised that question, DCJ not changing the dose. It cannot. If you and I go to DCJ, they will not accept it, because we are not it's not our molecule, and we are not, if you want to change that also you can do. Then we'll have to do register a phase 3 study saying that we want it as a regulatory trial and get it changed, because that nobody will do.
So basically the point which I'm getting, and Parikh sir, I want a final call on this. So is there any illegal issue on the what is written on the regulatory approval, and if someone tells no, this is not the right dose has been given, would you face a legal hurdle, or it is a straight time that you win this case?
Answer to that.
Okay.
Recently there was a judgment in which in Gujarat, in Ahmedabad, one doctor was suspended, license was suspended for 3 years because he did not use the right dose for anti-COVID medicine based on what was in the package insert. So though ultimately in the court you will prove that you are justified, but you will have to go through that mental harassment.
Mental harassment. Okay.
Yeah. So, you know, to say, I don't know COVID, what was it? But the pivotal trial in these trials were done on per kg dose.
Yeah.
And they have told the FDA that there is no difference between per kg dose and this thing within the 6%. So no court of law. You know,
okay.
If you go there.
So actually, can I add something here?
Yeah, sure.
The 2 milligram per kg, it is not just out of the blue why we are talking about.
Agreed.
It is a very systematic way where we have found out the flaws, the way the trials were conducted. And the company took forward the 200. The NEJM article said 2 milligram per kg to be forwarded. However, 200 milligram is also an option. That was the conclusion.
Exactly.
Okay.
So
Then.
We'll come to that. We'll come to the doses.
Because
we'll come to the doses, how it came to. We'll come to that, but I wanted to tell you.
Just want to,
yeah, please.
Because it's important to understand here. Why this? This CADIT, it is the organization in Canada which submit reports to government of Canada how to use these molecules. There is a complete 100 pages article what the scientists did is what we use at all these schedules we have shown, and what would be the pharmacokinetic and the dynamics properties of it. On that basis, Health Canada accepted across the board 2 milligram per kg.
Yeah, great. So I was coming to that. So if you look at it, till the keynote 024 came in, it was a 2 milligram per kg even approved across. The 024 was the study which they used a flat dose of the 200 milligrams, and since then it has been a flat dose. So actually it is in between all the famous studies what we know as keynote, the 024 was the first time they used a flat dose, and that is where since then the approval has changed across the world, and US FDA, every approval is a fixed dose for the Keytruda. So this is the point, but let's move on to the issues here. Data availability, because I think we should be talking on the data.
Again for data, the company's dossier.
I'm coming to that. Let's have a discussion on that. So data availability, and why we are talking of this so much is the budget implication, and that's what Amol you told. And this was the first of the studies which have been picked up from France, and they looked at per dose you could reduce the budget per euros by around 40 to 50%. So this was something when they did a weight-based dose and fixed dose, this was they did it because the approval pre-17-18 was weight-based, and then they changed to fixed dose. And they could find that there was a difference of around 40% extra they were spending for the fixed dose. So with this, in Indian scenario, this becomes pertinent because the top blue line is somewhere the Indian thing. Out of the pocket, around 70% patients still in 2016 are paying for the health care. While in USA, the last one, the red one is US, where around less than 17% are paying for health care from the pocket. So it does affect our population, especially with the per capita income we have. Even it's nearly, we are much worse on that regard, even for Thailand and Sri Lanka. So now coming to this, and Amol, I think you recognize this very well. And this is something I really wanted to discuss about the literature. I want to go to, and because this could become something will people might practice. So I thought I will discuss 5 to 10 minutes on this one. So the prescribed dose which you looked at 1 milligram per kg for Pembro. I'm not going to Atizo, there is data to that. I'll go to Nivo and Pembro. So I'll come down to again Dr. Anjana. Do you agree to the 0.6 milligram per kg once every 4 weeks for nivolumab as prescribed and advocated in editorial in Annals of Oncology? And we have one of the author, the lead author in a panel, and that's the privilege here. And do you advocate to this? And also you told you would not consider 1 milligram per kg. And this is every 6 weeks.
Yeah. So, this one is working. Yeah. So,
this is for the low and middle income countries.
Exactly.
I want to put it
low
right.
middle income, and also what I'm also realizing that since we are going to treat them for a longer time, and we want just control or palliation or whatever, we want like a longer period of time. So small dose, longer gaps are of course preferable in a low socioeconomic. I have not used it, so I will not.
Okay. So now I'll want Dr. Amol Patel come in, because if I read this study, and this is one of your references, which I've taken the studies actually, and I learned a lot from those references, and I thank you for that. So it was a phase 1 study of pembrolizumab for the anti-PD-L1 monoclonal antibodies in patients with advanced colorectal cancer. I go to a conclusion. And I went through the article also in detail. 2 things that stands out to me is that they tell that Pembro was well tolerated. They have done it, that they did it at 3 different dose levels, and also they started with 0.3 and went up also. So they have done the extensive study, although it was the early study. They have told that potential for anti-tumor activity was 2 milligram per kg every 3 weeks. And the thing that struck out for me was the 1 milligram per kg was once in 2 weeks. If you look through, the 1 milligram per kg is once in 2 weeks. It is not 3 weeks. So now, how do we advocate and think that a lower dose at a lesser frequency, which they have done? If you look at this, this is something they told that the 2 milligram per kg has the maximum efficacy. Beyond that, you would not have efficacy. But look at this study. The yellow bars are all 2 milligrams. The violet, the bar that is there is 1 milligram is this one. So this would be here. So look at, and this is 2 weeks. Everywhere the 1 milligram is 2 weeks. So can I come back to the recommendation which you put forward? How did you come to the 1 milligram? Because none of the trials have told 3
No,
weeks.
this is just one study. There are multiple other studies in which the biomarker, there is the interleukin 1 receptor occupation has been studied. And it starts very early.
Yes.
And the maximum response could have been seen at 1 milligram per kg for pembrolizumab.
Yes.
And it doesn't increase subsequently.
Yes.
Then the biologic half-life of these drugs are very huge. And it gives us.
Half-life is around 14 to 20 days for pembrolizumab.
Yes.
Yeah, it's 14 to 20 days.
So
that's why they do it at that frequency.
And when you keep repeating the doses, it goes on the target occupancy increasing, and after 2 to 4 doses, the stability is maintained. So if you're giving the heavier doses, you don't get that occupancy occupied with the heavier doses. It becomes static after some duration.
I understand that.
Yeah.
No, my basic point is, because this comes in a very reputed journal, people will start practicing, because we are short of money.
We are very happy, and I must convey this to Ian that people are going to practice this. We'll be very happy.
But I have issues, and that's why I thought the panel will bring out the issues. My point was, if you look at it, why it was there, and it is very important for me. And
this is just one study, sir. There are studies in melanoma and RCC that are different, and in those
I'll come to that. I'll come to that also. And
one more point that I want to forward.
I'll do that, and then I want you to answer that. The point what 1 milligram does is it did not sustain the responses. The responses was few, and the durability of response duration was lower in that dose, and that's why the anti-tumoral concentration and the best efficacy happened at 2 milligram per kg once in 3 weeks. And the 1 milligram across trials have gone for Pembro is 2 weeks. They never done 1 milligrams in 3 weeks. So point number one. So Amol, with this data, I'm coming to that. I'm coming to you. I understand we are just bringing out the nitty-gritties because none of us have shares in MSD. So
it is not listed yet.
Yeah. So my point is, Amol, now with this, are you convinced about that low dose for Pembro? I'll come to Nivo. I have the Nivo data also. Are you convinced about the low dose 1 milligram, or all of us agree 2 milligram is the way to go forward? Fixed dose may not be. That's okay.
What the point that we're trying to put forward is that, see, we have a country in which right now only 2% or 3% people are using it. So there is a gentleman in front of you who says that I cannot afford the full dose, but I can afford a lesser dose. Then that lesser dose should be offered to him, and it has been shown in the preclinical data as well as lot of trials based upon biomarker studies that the drug is working at a lesser dose also. One other point I want to put forward is
the receptor blockage happens. What I understood from it, at that dose the receptors get blocked. The efficacy and sustenance is not shown in efficacy data.
Yes,
that's the two
let us
different
understand. Yes, we do definitely require more of a clinical data to put forward and to put more pressure on, to have more sufficient evidence or to say that this drug works. But unless until we use it, how are we going to get the data? Other point that I want to put forward is that, which is very interesting point, is shown in those keynote trials that in 2017 they changed it from 2 milligram per kilogram to 200 mg.
Yeah.
Previously, pembrolizumab used to come in 100 mg vial as well as 50
mg vial. They've taken out those.
Suddenly they took out the 50 mg
That's
vial,
okay.
and suddenly they wanted to make
Banawali
200
sir
mg.
first and then.
So that is something which
Sir,
is
again we are not
difficult.
advocating for or against the company, we are only looking at the science here.
So
That's
one has to, when we are looking at the science, we have to look what is the commerce that is going on behind it also.
That's okay. Sir, you wanted to say something. I hope my point is clear what I want.
No, I agree, and I have another opinion on this. The first I told you, when the 2 milligram in this thing, in any court of law you will hold yourself. But in the second, unless there is a trial done, phase 3, and proven, it will not hold true. On the other hand, it's like patient does not afford and all, it's a secondary, then we have to take in writing and this thing. But there is a Korean trial which again I showed that if
40 milligrams.
40 is good enough, but that those patients who had very high PDL1 expression, they do well with even 40 milligrams. So, but that is different.
So there are a lot of riders
but
with that.
If you tell somebody without telling the other thing, okay, this is the dose and use it,
you might land up in trouble.
In any court.
Sir, you wanted to say something.
This guideline is in the perspective of that only, where how much patient is going to afford. Like one of my friend in Delhi is just using nivolumab 20 milligram, and believe me, after 1 year when he exhausted, he called me up. Can we?
I'll tell you, at Tata there's a trial going on. We are not very happy with the.
Sir, we'll come to that because this is beyond the scope of this. I'll tell you what happens in low dose, what I got the essence out of it. I was speaking to one of the two investigators Tata. I feel that the duration response will not be sustained for low dose. That's what my gut feeling is as I see this data. Sir.
So the question or the statement that patient says I cannot afford 2 milligrams, so can I take 1 milligram is a very dangerous precedent in general. If a patient comes and tells me that I cannot afford 100 milligrams cisplatin, give me 50 milligrams cisplatin, will we give it? Instead of reducing the dose, do we have another alternative standard of care which you can give in the full dose at the cheaper cost?
Okay.
So I think because of the financial limitations of the patient.
Okay. So one thing I want to point at 2 versus 20, enough data, and I totally take it. You see the AUC, and anyone who doesn't know this also feels both the things are same. That their data is there. If you look at the first dose,
approved. FDA is very distinct.
Yeah, first dose versus
like
the
Indian this thing, you know,
first dose and the down one is the 200 milligrams, and look at it, both are similar. So all of us agree that probably we can go for a weight based, and that should be fought up at a different level. But I think once it is a package insert, makes us comfortable as oncologists. So before I move on, I just wanted to ask our geriatrician here, if a patient comes to you and someone here wants to give immune oncology, do you do some specific things in your workup? Because in chemotherapy we know we have the scales and we look at it that way. In immune oncology, does those scales apply, or do you want to look at something very differently?
Yeah, I think as far as a lot of even modalities like chemo and immuno, what we want to do as, of course, as a geriatrician is like you even quoted, you told me that, you told us that it was an elderly male. So for me, the comorbidity status also matters.
Okay.
The fact that what is the activities of daily living, of course, I understand that.
And for immune oncology, does it matter that much?
Yeah, as well. And another important thing is we try to, of course, most people must have heard of G8, which is obviously the initial scale. But I always feel that the taking care of the comorbidities will always affect the treatment you are trying to give. And as far as weight is concerned, in older adults even more so, because you know that there is frailty and there is sarcopenia. So you want to document it and then try to take, for example, the dose that you're giving, this particular dose, is actually getting to toxicity. Of course, that is where crash and CARG will also come. So I think an overall this, which will help us to know, to at least know that the plan which we are giving is going to
you can
harm
at least the patient can tolerate it, potentially tolerate it.
Yeah.
Any geriatric scale for immuno-oncology drugs? No, I think all this are for chemotherapy. Okay, now from the Nivo data, and this is my last part of it before I go to it. This is very beautiful, and look, the first part is the lung cancer. You are right, Amol, actually, the melanoma and the RCC, the low dose work. And we have data and science for that. 1 milligram even works. And it is equal to 10 milligrams.
That is because the drugs, IO drugs generally work for melanoma only. Cancer.
But
it's the melanoma drugs which we are trying to take in every cancer.
But look at the lung cancer data, and the most of the bulk of immune oncology drugs in India are used in lung cancer, and we have to accept that. Look at the lung cancer data, and that surprised me. Look at 1 milligram, the numbers are small. These are phase 1 data published, NEGM publication. 1 milligram, 3 milligram, 10 milligram, the Nivo data. And if you look at it, the 1 milligram data, responses, absolutely nothing to talk about. The stable disease is there, not there. The progression survival 24 weeks is also dismal. 1/3 of that is for the 3 milligram dose. So if you look at this, does it feel that in lung cancer, the low dose will not be doing good? Because that is what it is. And if you look at across trials, I have then walked through trials, the duration of response actually is the main thing why we are giving immuno-oncology drugs. The tail, what we took, and that is lost probably in some of the lower doses. Namol, first you, what do you think of the lung cancer data? Melanoma RCC, point taken. I don't want to put that.
Again, that depends upon what is the PD-L1 expression. If we are using the low dose in the high PD-L1 expression tumor, it may work.
So more than 50% fine, but less than 50%?
What is happening is that most of our approvals are now beyond PD-L1, irrespective of the PD-L1 the drugs is being used.
More than 5%, more than 5% where the Nivo approvals come.
In fact, for Pembro, there is no PD-L1 cutoff required for lung.
No, along with chemotherapy. For single enzyme Pembro, there is a cutoff. That's true.
So my whole point is that if the patient is having robust PD-L1 expression, probably the low dose also will work. Of course, we require to generate our clinical data, that is definitely. But we need to work on that because it will be beneficial for our patients. Right now, only 2% are taking it.
Now, okay, so what I wanted to point out is we still need to work on trials. That's what I felt true. The data at the low dose is lacking. Probably the Tata will come up with their data, and that will give a very big push to yes or no to this thing which we want to. And if that is a no, it will probably push this thing back. That's what I feel as a medical oncologist, sir.
More than doctors, our study coordinators who are there come running to us, so.
Sir, I think we are censoring this part of it
now because it's an ongoing trial. So, but I'm just telling you.
I understand.
You know.
Okay, we have 1 minute and finish. The vial availability 100 milligrams. Are you comfortable with vial sharing? This category of patient are comfortable with vial sharing? Don't. Anyone does here? Army, it could be. In private, can it be done?
Can you pull up the patients?
In TMH, sir, do you do vial sharing?
In TMH, we indirect one-on-one basically at patient level, but now shortly we'll have a central.
So central pharmacy type, the nice type of thing.
And we will be selling the drug at per ml, per
10
milligrams.
So I think it is doable.
That is really great.
In regulated government settings, but in the private it is a far dream because people feel I would not take a used drug. And even there was a very good data from West, which in the West even 20% patient felt I will not share my vials. In India it will be much more. So
there is another point.
They have circumvented this by pulling the patients and calling them on the same day.
Ma'am, they've circumvented it in those scenarios like in UK. You get it from the government. You get it or you get it out of pocket. Out of pocket they cannot afford it. So you get it from the government. So that is only where it works. Like in the army, if it tells it is this way and the system works, it will work. They don't have option, the patients.
Coming on the same day. Coming on the same
It can, but sometimes patients won't come, 5 will come.
Sir, on your
There is another point which we had put forward in our article also.
This option of which is there and people have accepted the vial sharing would be option to.
Apart from the vial sharing, the stability of the diluted drug itself is the drug remains stable for 14 to 21 days, just like trastuzumab can be used after the vial is opened for 4 weeks. Pembro also can be used, and there are studies done by Merck itself which have been published which shows that the vial is stable.
Stability mentioned in that packet insert?
The vial stability is not mentioned in the package insert, but there are studies published and done by Merck only.
Okay. The last question.
When trastuzumab came first, that time there was no such data that the vial can be used for 4 weeks. Later on the data has come that the vial can be used for 4 weeks. Same thing will happen with Pembro eventually.
That will probably help us a lot. Yes. If that comes in, that really helps us a lot. Because now to you, Amol. Will it really reach the masses? Yes, sir.
But the company in the package insert prints one-time use. They are very. So that again will go in court of law.
Will again go. So till it's printed,
patient, you cannot do that.
At Tata Hospital, we had a patient who complained about this. The gemcitabine dose.
The low dose which you used.
Yeah. So they were not complaining about the low dose. They were complaining about
open vials.
Open vials. And whether the actual problem was the nurse had diluted more than required. So we said we will use it next time. And they said no stability like that. Fortunately, a gemcitabine study was going on. So the index that is there, the drug index, we could show them that the stability is there for 3 months, and then they. So it could be a problem, but there are ways of circumventing.
Okay. So now the per capita income of India in 2021 is 1,26,000. So still at 40 milligrams can Indian patient afford? So
that is the next challenge. Problem is that
that is my first challenge. So if I make it 40 milligrams, still can it be affordable because my per capita income is 126, estimated to be 150 in 2022.
Yes, I mean that is going to be difficult with that low dose also. But first we have to at least reach to the low dose, then we can think.
I am with you. I am on your side. I am just on the moderating. That's why I am.
But you know, 2 things here. First is there are many people now who are helping out, like Cancer Cure Fund is there and all. So first is that, and second thing, you know, this will be ready by the time Indian companies come and we have, when the cost we have ready, this thing that okay, we don't have to use higher dose. So both ways.
So generics would be a good answer. Yes, that's what it is, and then the weight based really takes it further down. And if you have a data from TMH probably positive, then it can be really the low dose also comes in. That's how it will move forward.
Our discussions are so realistic, and sometimes they are away from the reality. Every day we see in the practice, though I am from armed forces, we also face a lot of difficulties in getting all these molecules. ऐसा नहीं है कि fund आ जाए. We have to answer so many things, and there is a reason for rationalization at every level. Even working in a corporate level, you have to be rationalizing the individual affordability. If he says that this is my budget, and I see many such patients, I also get calls for the second opinion and all of these things. there is a reason to practice the science in a different way.
Where it helps the masses also.
आपके सर भोपाल में भी बहुत ऐसे पेशेंट हैं, आते हैं,
लगभग सभी आते हैं,
सभी आते हैं और बोलेंगे सर 200 नहीं है साहब, 40 मिलीग्राम के 5 डोज दे दो, 2 महीना 4 महीना खींच के देख लेते हैं.
Only thing is the legality is where I get
for that. That is what we mention in our
how,
article.
how can we allow the patient to dictate the dose based on their affordability?
We are not allowing, we are
not,
suggesting.
you are saying that.
We are suggesting.
No, absolutely incorrect.
We are not saying, we are suggesting it.
If there is a expensive medicine which you have to give half the dose versus a cheap medicine which is also standard of care, I think we are fully justified only in giving the cheap medicine which is standard of care and not the substandard dose of an expensive medicine.
75-year-old male comes in my room whose both sons are working and they says that हम दोनों मिलके एक 50,000 तक महीने का खर्चा कर सकते हैं, हमें बेस्ट ट्रीटमेंट दीजिए, हमें बेस्ट ट्रीटमेंट दीजिए, उसका PDL on expression 70% है. What would you do?
So exactly what I'm saying is that I would give Gefitinib.
How can you give
Why not?
PDL1 expression? Why
PDL1 expression doesn't change the standard of care. What is the standard of care? Why not?
Sir, time out. We will move to some other thing because we are already out of time. Novel ideas is my last thing.
I will say that Dr. Banavali just pointed out, if you are sitting on the other side of the table and helping out the patients and out of pocket, it was so easy initially to look at the estimated cost of chemotherapy and grant up to 5 lakhs in Cancer Cure Fund. But now it is getting so complicated because of these small molecules being requested for. And there, like it started with Herceptin, Enzalutamide, short versus longer duration of that trial, and which has come up 12 months in adjuvant setting, and so on and so forth. So it is a Pandora's box. So we have to do something for even the NGOs who are trying to support.
It is also very difficult for them.
It is very, very difficult. Every time we are spending time discussing the same thing over and over.
So the novel idea is low dose immunotherapy with metronomic therapies. Some data
in head and neck cancer, that is
any of this thing, but there is rational basis.
So the novel idea, what is being proposed, I think there's a study going on in TMH, the metronomic with the immunotherapy low dose, and they want to combine the things and then prove it. If the publication comes, I think it gives us a lot of heart and proof.
I would suggest first take RCC and melanoma, publish it in a
Okay. So can I ask one last question before I move to conclusion? How many of us here use Abiraterone 250 as a standard? Is irrespective of Ambani's or Tata's come to me? 250 for everyone or for unaffordable? That's the point, sir. My point is, if there is data and science tells us the 250 with food is equal to the 1000, why should be differentiation between a rich and the poor? Because I talk to the things, and when it's unaffordable, I'd use 250. If it's affordable, I use 1000. Then I think then that's used. We still believe 1000 is the standard. Okay. So I think if we have to first change in lot of things where already science is there, and still all of us do believe that 1000 is still the standard. I've asked to many of my colleagues, हाँ पैसा नहीं है तो मैं 250 देता हूँ, पैसा है तो मैं 1000 देता हूँ.
But at least they are giving option of 250.
Yeah, definitely.
Because
there is
they
data.
want to give that option at
because there is a very strong data, and that is why the option is there. You have a good publication of pharmacokinetics, that's all you want, and the efficacy data is equal. That the publication tells you two things, and that I am happy as an oncologist there. I think we can read it once again.
You won't need their phase 3 trial.
I don't think we ask for phase 3. No, real world studies and in a trial control is very two different things. I think that's where it is. Okay.
Can I ask one important question?
We are the last one.
In relation to what Amol and I were just discussing, let us say the patient can't afford the new standard of care. Okay, the old standard of care, the phase 3 marketing approval pivotal study has shown that there is a 20 months, 5 years, 20 months survival, median survival is 20 months. Now, there is no data to say, there is scientific rationale, but no data to say that a 50% dose of the new drug is going to be giving X amount of survival. the full dose of the new drug, new standard of care is giving 40 months survival. Should I use 50% of that new drug or should I use full dose of the old standard of care? Because one is proven and one is conjecture, which is my perception, my belief.
Actually, you are putting the things in a reverse order. Here is, I am talking straightforward. रिवर्स वाला सीक्वेंस से काम नहीं चलेगा जैसे
आप बोलो ना you tell me
मैं बता रहा हूँ काम क्या होता है
Pembrolizumab
सिंपल कोई पेशेंट आता है तो इस जस्ट सिंपली स्टार्ट विद पेम कार्बो देयर इज नो प्रॉब्लम बट अगेन आफ्टर सम टाइम 4 months पेशेंट प्रोग्रेसेस द सेम पेशेंट एंड द फैमिली कम्स अगेन हमें सर ये पेम्ब्रो हम पढ़ के आए हैं बट हमारी औकात नहीं है
So in other words you are influenced by the patient's perception.
I have to be through the patient's perception.
Okay, so before I end, I have to really congratulate you because you just started the discussion which was much needed, and really that is something where the things will change. So that is the point number one, because I would have never read till that WhatsApp chat they really came in, and that's how I think all of us get knowledgeable. And I would not have read this whole references because it was your hard work which I went through. It was easy for me to get those free references. All the references are free. So it was good for me. I could download it and read it. So I've learned a lot. What I did find as a conclusion is it is time to change. One thing is very sure that weight-based is the way to go for immuno-oncology drugs. That's for sure. Taken. Fixed dose is something which I feel is not helping our patients' cause, especially for Indian population which is 40, 50, 60 milligram kg. That's point number one. For the lower dose, I still believe for the bulk of the patients who are head and neck and lung cancer, the data is not rich enough to practice. Melanoma and RCC. RCC is the number one for me if you ask for me. Yes. Yeah. MSI. So there is where I think the discussion can go and there's some science to it. But in lung and head and neck, which is India's cancers, there is still not a big data. I think the Tata data.
Should I confess one thing?
Yeah.
Same discussion I had with the other two co-authors.
Okay. So at least.
No, listen. Then we had another discussion for other two trials. In that, the interleukin was the main.
Yeah. So for the interleukin point, why I did not.
Interleukin is such a.
I know, but once the balance happens, this is.
The responses.
Yeah.
When you go for the responses.
Yeah, the response is something, the duration response. Okay.
From that level.
Okay.
That is the agenda. And when I said that, let's do a RCC trial. When I started working on low dose nivolumab, the budget was 3 crore.
Okay. Yeah.
नहीं हो सकता हमारे low dose trial भी नहीं हो सकता.
So to conclude, in chemotherapy, it was always body surface area dependent because it is so close to the heart now, it will just come in. So immunotherapy, it is waste-based approach, is more logical. That's what the evidence is today. It saves money without compromising efficacy. And I think the fixed dose approach should be taken away. Even if you look at the latest approval for nivolumab with GE tumors, it has come to as a fixed dose, surprisingly. So again, we are shifting in India also to fixed dose. In the Nivo, which was always weight-based, in Nivo, in the GE, gastrointestinal, it has come to now weight-based, fixed dose. Toxicity is not an issue. That's very clearly told. Higher dose, it does not add any other benefit. My only thing is, KOLs like you and sir is there, and sir definitely we come back to, should advocate for a weight-based approval. I think how we can write to a drug controller to do that for the safety of the doctors practicing is something I think, sir, at your level you can think about. It is beyond my comprehension and my capacities.
See, again, my thing is that already is published. I don't think in court of law, and they have even the approval is with that caveat ki there is no difference. And that is why we are giving this, because otherwise
is it written in that approval?
Yeah, in FDA approval it is written. That's why I'm telling you.
So what is in our hands to do
sure,
is we publish something officially in a peer-reviewed journal under the banner of ISMPO, stating this is our recommendation.
Sir, I have one more question to you. With the editorial which is in Annals of Oncology, which is one of the best journals, all of us read that. Will that be a good enough support if someone wants to practice it?
So definitely it is a support.
It does help. It does help.
It does. That is. But we have to specifically put the guideline saying this has to be done or this should be done.
Now we have done.
Yeah, you have written the.
So those articles, see, correct. Anything that is published by a body of respectable, doesn't matter. If it is nominated by the organization, it is even better. But a peer, if somebody is filing a case against me, my peers, that means all of you, if you have published something, I can produce it as genuine evidence in the court of law.
No, but here, here, just to tell, here the company has published that data, na? The pivotal trial was on 2 milligram per kg.
So that's why I put this as a conclusion.
I don't deny what you are saying. What I am saying is, if we want to do something else, what is in our hands is to publish under our society's name as a guide.
Okay. So thank you. I thought I could bring in something more and bring in the little bit integrities which people just read the article and don't go into references. I thought I'll do that. We are at the end of the day, so no one is there to listen to us. But still we had the tempo going. Yeah, I think this was useful. So thank you. Ma'am. Sir, Parik sir.